Welcome, everybody. We're so glad you're able to join us. I'm Mary Maddox Gonzalez. You can see my some of my background there. And again, in the interest of time, I'm going to go straight to our speakers. This is funded by the California Department of Health Services State Opioid Response 4 grant. And the project is part of the SOAR grant, and the contents and views are those of the authors and presenters, don't reflect the policies of DHCS or the Substance Abuse and Mental Health Services Administration. So it's my great pleasure to introduce Dr. Ashley Herrera. She's an assistant professor in the Department of Social Work at California State University, Bakersfield. She's trained as a licensed clinical social worker. She's been conducting addiction research for over 10 years, working with community-based organizations, healthcare, governmental organizations, designing, implementing, and evaluating work on overdose prevention, naloxone distribution, street medicine interventions, and harm reduction vending machines. She founded her own nonprofit, Hope in the Valley, which has expanded access to evidence-based harm reduction strategies in the Central Valley of California. Welcome, Dr. Herrera.
What I'm going to be discussing is street-level solutions for overdose prevention. Next slide, please. One of the framings I think is so crucial as we're stepping into this conversation with one another is recognizing the disproportionate risk for overdose amongst persons experiencing homelessness. We already know about social determinants of health and how critical housing is for health and wellness, but we see this problem play out even more severely for overdose deaths, with folks experiencing homelessness being up to 39 times more likely to experience an opioid-related overdose death. And this is the leading cause of death amongst our unhoused community members. So working towards solutions that make sense for this population are so critical in our life-saving efforts. Next slide, please. This is a picture from our community. Some of the folks that we work with on street medicine came home one day and found their community in shambles. And this is a reality that's happening to folks across the United States on a weekly basis. And in social work, sometimes we do a lot of guided imagery where we ask people to envision something that's kinder and gentler to help them feel better. I'm going to just ask everybody, in their mind's eye, to imagine that you've come home from work and you found your entire neighborhood demolished. Your home is gone. You have nowhere to sleep. Everything you own, valued, treasured, has been thrown in the trash can, and the people that you love and are connected with in community are no longer there. They're displaced, and you don't know how you're going to find them. And this is the reality that we're waking up and facing every day in the United States. So fundamentally, why I'm sharing this story, why I'm sharing this image, is for us to think about how encampment sweeps create ontological insecurity, right? Which is the idea that folks lose fundamental trust in themselves, in others, and in the world, that things will be stable, secure, predictable. It's no longer there. So that's what we're up against when we're trying to engage people and design overdose prevention strategies that are really going to support them. And so, of course, it's so tragic. It's so devastating to experience your home being destroyed in this way. But also part of their home is that they're naloxone, right? And there are other supplies that are helping them to prevent overdose. So we can see that this practice, when week in, week out, folks are being swept. They are losing access to the vital resources we're working so hard to connect them with. Next slide, please. So in addition to losing naloxone and other supplies, we also know that folks are losing their medications, including medication for opioid use disorder, another life-saving tool to prevent overdose. They're losing their vital documents that let them do things like access NTPs. And of course, they're experiencing trauma, right? This is very traumatic. It leads to mistrust too. Who has let them know that their encampment sites are there? Are you going to do the same thing to me? Are you going to report this? Are you going to harm me? And that leads to increased isolation, right? Because then they have to find new areas to try to camp, to try to survive, and that's to be out of the view of others. But that means that they are more alone. And then we know when folks are alone, there's no one to administer naloxone and save lives. So of course, all these together are driving overdose and death in this community. And if you're looking for more references, you can scan the QR code and see some more of these really powerful studies. Next slide, please. I did just want to provide some images in our community. What does integrated street medicine look like? Bakersfield is a large suburban community, a little under 500,000 folks living here. But again, as people are trying to avoid the eyes of code enforcement, a lot of folks have settled along this area called the Kern River Parkway. And in this riverbed, you can kind of see next to the trees, there's some encampment sites, and there's only one road through. And most of the time, the people driving on this road are going to be code enforcement looking and actively searching to eradicate encampment sites. But along the same road is also hope. And it's how the street medicine team accesses this group of unhoused individuals in our community. Next slide, please. We're really fortunate in the last 6 months to be able to expand this practice to one of our more rural communities of less than 50,000 individuals in Delano, California. So again, the practice looks really different here, where folks are mostly encamped along freeway underpasses or next to train tracks, other places they can try to limit visibility. So that really speaks to how different street medicine can be on a place-by-place basis, and how that's going to shape that this national, international movement really becomes something that has to reflect the local needs of your community. Next slide. So keeping that in mind, this is one practice being practiced across many settings, and the importance of having those adaptations to street medicine so that the core philosophy, the core practice, and the core interventions related to overdose prevention are successful regardless of the community that you're practicing in. So like we're talking about, this looks different, whether you're practicing in urban, suburban, or rural settings. One of the things that is really crucial to consider is drive up and road access. It seems simple, but it's actually complicated, right? So in a lot of our urban areas, teams are in cars, they're able to pull right up to sidewalks and other areas that are accessible, through a vehicle. But other areas like the river, will drive up along the main road, but then you have to, disembark from the car, bring the supplies down, and reach where people are because the vehicles cannot get down the slopes of those riverbed banks. And similarly, when the train tracks, it's very easy to pop a tire. So we're gonna, park somewhere that it's a little more friendly to our vehicle and walk in. The same thing, folks are behind the freeway underpass, so we need to walk in using backpack or some kind of wagon kind of approach to bring in supplies that are needed to support the folks. I think what's really crucial is that we understand that our priorities, especially folks engaged in healthcare and behavioral healthcare, we may have some goals for what we would like someone to do. But we always have to go back to the core philosophy of this model around patient-centered care, autonomy, and self-determination, and understanding that their needs look very different than our needs because I'm not waking up every day wondering, do I get to eat? Right? So recognizing the really complex and competing priorities that need to be addressed first before we can move to some of these more advanced interventions. And that's a critical way that we build trust by showing them that we understand what they need most. Of course, trauma-informed practice is a key element of that as well. Thinking about how we show up in their space. Are we showing them that people can be helpful and not harmful? They can be non-judgmental instead of creating social violence and exclusion. And that's through every interaction that we have with them. We also have to consider, what's the team structure and size? That's going to vary from programs. How much money do you have for members of these teams? Is there an opportunity for student trainees so we can expand upon this practice and train the next generation of practitioners? Who should be included? Is this mostly a medical model? Do you also have space for behavioral health providers, community health workers? And again, that's going to vary agency to agency in terms of capacity and funding. Also, what each team is able to do is subject to state law, right? We know that jurisdictions across the United States have very different rules related to drug paraphernalia, and that's going to play out in the practice as well. We also know that in some communities, doctors have more ability to distribute different types of supplies than perhaps nurse practitioners or physician's assistants. So again, who is on the team? What are the rules? It's going to dictate how you're able to implement some of these practices. And then, of course, organizational policies and procedures related to the distribution of supplies and dispensing on-site medications. Next slide, please. What we found through our recent research, we've been conducting some qualitative studies of patients and providers engaged in street medicine. And we've seen that, in fact, street medicine has the potential to build ontological security, right? Through 4 components: material and social constancy, privacy and control, helping patients to build positive self-appraisal, and to build health routines. Next slide. So in terms of material and social constancy, what can that look like? First, it's that you're showing up on a consistent basis. So if you're going out Thursdays at 7 a.m., you're there every Thursday at 7 a.m., or some iteration of your team. right? So that they know that you're going to consistently show up no matter what. And then you're showing up with things that matter to them the most, right? Like food, like hygiene items. And a lot of the folks that we serve have pets. And that's a very important part of their safety, not just emotionally, but also physically, being unhoused in the streets. And so that you're showing up with pet food. A lot of times folks will ask us for resources for their pets before they'll ask for resources for themselves. And I've even had times when folks didn't want to see the doctor and said, I wish the vet was out with you guys today instead, right? I want my dog treated first. So again, understanding the priorities of the people that we're serving so that we can build trust, engagement, rapport. So every time that we're showing up with something they need and creating that opportunity for that dialogue, that conversation, that relationship. Next slide. That's also accepting the reality that the folks that we're serving are most likely to experience and witness overdoses. So how can we show up for them with the tools and supplies they need to keep each other alive? These are the first responders in these communities. So every opportunity that we can, we're bringing out naloxone. Every visit, drug checking supplies, right? And then other equipment that addresses the realities that they're facing in their environment and where they are if they're struggling with the disease of addiction. Next slide, please. And medication for opioid use disorder, right? This is an incredible opportunity because we've created access, because we've created relationships and dialogues, we can have psychoeducation about MOUD. We can do low dose buprenorphine initiation if that makes the most sense. We can do field administration of long-acting injectable formulations of MOUD. This is being done in our community every day. Part of that constancy, right, as you're onboarding folks to medications is that you're able to keep checking in, keep bringing the medications to them, keep them on that schedule, even if you get onto a monthly LAI. I know that I'll be back at this time and I'll see them again so they can have the next injection, right? And we've seen that, again, in the data with our patients, saying how easy it made it for them to be able to start MOUD because of the work of street medicine doctors, because they promoted health literacy, because they made the intervention accessible, cutting strips for them, bringing it to them, right? Breaking down barriers that otherwise would preclude them from accessing life-saving medication. Next slide, please. Some of the best practices we found, we were so fortunate to work with RTI and their Sia naloxone trainer. And so we have used an opt-out model for naloxone. Every person we see, we're asking them if they want naloxone or not. Even if they don't want medical services or anything else, you are going to get offered naloxone. And we've done the same thing with drug checking strips as well, so that folks have access to these interventions. We're also going to follow up and ask, do they need any additional training around these resources? Is there something that we can do or show them to help them use them better, information they might need? We leave behind cards as well that provide the signs of an overdose, both in English and Spanish, thinking about linguistic accessibility for your communities, and modifying resources to reflect those needs. As you saw on the previous slide with our product list, we also like to use a lot of images. Literacy can be a barrier for folks. And then if we have pictures of something, it's easier for folks to point to them to say what they want, breaks down some of the stigma, makes it more accessible. We also like to include QR codes. If people do have access to a phone, they can view different types of videos. It helps them to also understand what we're talking about, and they can review things on their own time once the team has left as well. We always try to move to a needs-based distribution model. So as much as you want, as much as you get, you're the expert on your own life. You know what you need. I'm not going to try to gatekeep resources from a scarcity mindset. If I have it, you're going to have it. I'm not trying to keep it from you. We use a lot of positive reinforcement for naloxone uptake. We thank them for taking it. Thank you for being so willing to save a life and to show up for your community. When they shared that they've reversed overdoses, we are so excited that they were willing to be a hero and save the lives of those around them. We've seen from research before that when folks do reverse overdoses, this is something that really helps to build with that positive self-appraisal we talked about earlier with ontological security. And then, of course, we want folks to know their rights. This is a community that frequently interacts with law enforcement, and that's not always a positive interaction. So knowing what they are allowed to have and then how that's going to inform their decisions and safety. Most communities do allow folks to have drug checking supplies, and it's not considered drug paraphernalia. But in some communities across the United States, those legislative changes have yet to happen. So again, letting people know what's their risk. Next slide, please. So the next element of ontological security is privacy and control. So it really starts with informed consent, working with the patients, engaging them in shared decision making, and honoring their confidentiality in terms of the information disclosed, and that we're taking folks as to the best ability possible off to the side to talk about sensitive topics so that they feel like they're having their privacy respected and valued in these spaces. And this again came across really clearly in the data. Jose is saying, with street medicine, I'm allowed to decide what I am and am not comfortable with. I like the doctors and the team, so I keep seeing them. Again, that element of autonomy really allows the patients to set health goals, work toward health goals at a pace that is acceptable and possible for them, and leads to this long-term engagement where we see in traditional healthcare settings, they are so disconnected and oftentimes excluded, which leads to really negative health outcomes. Next slide, please. And overall, when we talked about how we engage with folks in a trauma-informed, patient-centered approach, using non-judgmental stance in all of our interactions leads the patients to rebuild self-appraisal in a way that's positive, right? There's so much stigma, there's so much shame that they're encountering, and it becomes internalized and disconnects them from healthcare, but also makes them feel helpless, hopeless, and that they cannot affect change. And when they start to interact with healthcare professionals in this new way, where they're treated with dignity and respect, when they're not judged for disclosures around substance use, mental health, housing, right? They start to have a renewed sense of self-worth. They start to trust healthcare systems again. You see enhanced self-efficacy that leads to increased patient activation. And this was really captured here about Amanda, talking about the stigma she encountered as a drug addict and that she really internalized that and then felt people didn't like her. And after interacting with the street medicine teams here, she said, I feel good here and I trust they'll take care of me, right? How powerful, overcoming medical mistrust, and ultimately, Amanda did agree to initiate MOUD. So really exciting outcomes. Next slide, please. So part of our research, we built this model overall, talking about how street medicine versus traditional healthcare services, either improved or reinforced ontological insecurity, and that ultimately allowed folks to build health routines when they had access to street medicine. And what patients were saying, in interview after interview is that I got my medication and I take my medication, that for the first time I'm getting blood work done and I'm able to get those results. And then that improves, what's going on with my medication or my health, that they're able to attend specialist appointments to get the specialty care they need, that when they were at risk of losing limbs, they had that daily connection with nurses and providers who were tending to their wounds and they didn't have to have their arm or their leg removed to have it amputated because they had that kind of care. And ultimately, what we see is that folks have improved physical and psychological well-being, and there is this re-engagement with healthcare overall. Next slide, please. So the work is really challenging. We know with encampment sweeps, the naloxone cascade is being damaged on an ongoing basis for the people who need consistent naloxone access the most. So we're always looking to novel strategies for how can we work to improve it. In our community, we did an innovative intervention where we trained all the pit count volunteers and had them distribute naloxone during the pit unsheltered count. And this really allowed us to leverage existing resources to have a big impact just one time, but still an important time to get naloxone into the hands of those who need it the most. So highly encourage folks to join their local homeless collaborative, partner in this work, think of additional novel strategies, adopt this intervention for naloxone education and distribution during the pit count. We have some of our publications here for your review if you're interested. But thank you so much for your time and the work that you're doing to save lives and rebuild trust in populations that have been socially excluded and harmed and are dying and need us to have more compassion and more resources, especially during these difficult times. Next.
Thank you so much, Dr. Herrera. We're going to go right into our next speaker, Dr. Reb Close, who attended medical school at UCLA and did an emergency medicine program there, residency. She did 20 years in emergency medicine, then got her board certification in addiction medicine now does addiction medicine since 2022. And she practices in various settings. She sees patients in an outpatient setting, doing street medicine, and she's one of the Central Coast Overdose Prevention. Also works with the California Bridge program, a great program linking more than 50 to 60% of California hospital emergency departments to care and MOUD treatment. Reb, Dr. Close, please.
Yeah, thank you. And thank you so much, Dr. Herrera, for that beautiful overview. Makes my part really easy. I just get to talk to you about what I get to do on the street. So this is kind of the nuts and bolts of how to make it happen, as much as that's possible in the time that we have remaining. So I'm going to fly with this because I want to give the other speakers some time as well. But this is me on our street in Chinatown. There's kind of the background. Next slide, please. And truly, so Central Coast Overdose Prevention is the nonprofit that we founded. And the whole point is to meet people where they are, whether that's in the carceral setting or whether that's on the street. And so literally this is us at the tracks. This is my crew, and a pretty significant portion of my crew has lived experience, and they're the key to this work. Next slide, please. All right, so again, here we are out on the tracks. We take Narcan, we stick it in the trees, we put it on the top of the fence, we put it anywhere, next to someone's encampment, anywhere that we can get it so people know it's readily accessible and available in times of need. And we will literally, we park exactly as it said, we will park our truck at one side and just walk down the tracks because we can't take the vehicle there, but that's where a lot of the encampments are. So that's where we go. Anywhere that our patients are, that's where we're ready to go. But as well, with permission, we're very respectful. These are their homes. And thank you very much for mentioning that, Dr. Herrera. We need to be incredibly respectful and appreciative that they're allowing us into their space. And with time and with some familiarity, that has become more of the norm, but we're still very respectful as patients change and new people are welcome to the community. They may not be as familiar with us. And so we need to, again, ask for that permission and show that respect. Next slide, please. And so as it was mentioned with dog food, cat food, toiletries, tampons, condoms, whatever it may be, we're there to try to break down those barriers to get people connected to care. Additionally, with harm reduction and mental health support, we do provide basic medical support. We have the wound care kits. We have the physicians that partner with the peers. So if someone has a question about a wound or if they need a prescription for an antibiotic, we're right there on scene to do it. And then again, we can initiate MOUD as indicated, and we've started doing direct to inject in this setting. So literally last Friday, people were asking, they'd heard some of their colleagues had gone through direct to inject and things were going well. So we have more people lined up for this Friday. And I just got a call prior to this meeting starting from another patient that's hoping to start this Friday with the direct to inject. So if someone is hoping to get into treatment, we are hoping to figure it out for them in whatever way works best for them. Next slide, please. All right. So we also prioritize kind of immediate post-overdose or EMS intervention, AMA patients. So as part of our EMS buprenorphine work, I will receive information on patients that have engaged with EMS for an acute substance use related issue, which may be an overdose. That patient may go to the hospital where they connect with the substance use navigator, or they may leave the scene AMA or against medical advice. If that is the circumstance, I send what we call our CERT, the substance use response team, to that person, literally just to the last location that they were known to be at or their last address with, we're here to provide support and services. Here's a bag of goodies, as we tend to call them, of Narcan and various other supports. Is there anything else we can get for you? It's very open, non-stigmatized, and we will mention, we heard there was some trouble yesterday. How can we help? I mean, we don't say we heard you overdosed or anything like that. That's crazy. We're open for what they're needing, and we try to bring that to them. So we target areas or circumstances where it seems like there's the greatest need, whether that's geographically or if someone's had a recent event. So we just go where the patients are, and it works out for our team. Next slide, please. We also do some education. This on the left, We were invited into the youth center, which is kind of an extension of our juvenile justice system. We go in there, talk to the kids, engage with them as well. And again, bringing peers, that's the cornerstone of all of the work we do, is to bring our peers. And many of our peers actually have been in the unhoused status, on the street, past history of using with the patients that we are trying to serve. That breaks down the barrier faster than anything. Next slide, please. All right, and then we partner in every way that we can. So I mentioned the EMS buprenorphine project. We obviously do naloxone now. We put naloxone boxes anywhere someone will take them, including the gym that I go to. Again, we go into the jails as well to try to connect people with support on release. And we will send the substance use response team to the jail to do a pickup. We actually will also have the patient's medications. We'll have buprenorphine in hand and give it to the patient as we take them to their safe destination on release from jail. So we're able to do that and mobilize the team for that. Next slide, please. And then, as I mentioned, the partnerships. And I think that's really why we are able to have the successes that we do. We work with law enforcement behind the scenes more so. Sometimes law enforcement will take us to an encampment and then they just step back. They just want to make sure we arrive where we need to be safely. And so the community has gotten comfortable with that. Obviously, we even go into the libraries. We put Narcan boxes there, working with our board of supervisors, all of the hospitals in our region, our EMS buprenorphine partners, and then any of the CBOs in the area. So we work with our syringe exchanges. We have a mobile van that does medical and dental. So if I see someone having a lot of questions about their dental care, I take them right over to the mobile van. So we really kind of network to make the community safer with bringing together all of the partners that have different services. Next slide, please. These are just a couple of quick photos of other places. We'll just drop Narcan off. Next slide. And then just, we have some goals to build in sustainability. We're getting everybody credentialed with peer support specialist, community health worker. We do training such as de-escalation, motivational interviewing, trauma-informed care. We're getting all the team up to speed on what we can do to do positive interventions. And I think my last slide is a thank you, and I'm gonna pass it to our other presenters because I wanna respect everybody's time here. And thank you.
Thank you very much, Dr. Reb Close. And I really appreciate Dr. Herrera and Dr. Close, your presentations, and you're kind of having to sprint through this. Our apologies, but it's such valuable information. Really appreciate it. And our next speakers are Raymond Cordemanch, and who is a health and human services leader in Solano County, California, and has worked extensively with medical services, regulatory compliance, worked with, is very effective at building relationships and fostering collaboration with community partners. With him today is Dr. Christina Kinnevy. She's a family medicine physician, but similar to Dr. Close, she now has obtained board certification in addiction medicine and works at the county, also works at MedMark treatment centers and Archway recovery centers, where she's the medical director. She's also an associate professor at Touro College of Osteopathic Medication and co-chair of the Drug Safe Solano Opioid Coalition. Welcome, Dr. Kinnevy, and welcome, Raymond.
Yeah, thank you so much. What a pleasure it is to be with you, Dr. Reb and Dr. Herrera. Thank you so much. And the smart one in this relationship, by the way, is Dr. Kinnevy Gregg. So just so you know that. Just quickly, I had the privilege to start as an intern in a methadone clinic when I was 25. Here it is some 3.5 decades later. So this work that I get to do here now and present with Dr. Kinnevy Gregg has been the most rewarding work, by the way. So I'm just going to give an overview of an element that we've introduced to our street medicine through Dr. Kinnevy Gregg and her leadership with others. So this is a Drug Safe Solano Touro University mobile outreach bus, from the vision to reality, as it says, taking care on the road. And next slide, please. Again, why the bus matters. 1, 2, 3, 4, right? Meeting people where they're at. People are our priority, right? With compassion, with care, and resources. Why? We want to expand our outreach to the underserved. We want to support harm reduction and overdose prevention. And we have a desire to increase mobile access to our behavioral health resources within Solano County. Next slide, please. The transformation. This bus was donated to us through our previous provost at Truro University. It sat for a couple of years, and Dr. Kennedy Gregg was approached, and Mary was like, hey, we have some innovative funds. Would you like to do something with these resources? And we took this bus that was damaged, that was robbed of its mufflers and catalytic converters and busted windows, and we've converted it to a functional mobile clinic. Smart enough, I reclassified it to a Class C license. So now, therefore, now our interns, we just led 30 persons through the state peer certification and going through that process. Our interns can actually be qualified to drive this bus. Hence, I removed the Class B passenger restriction. Next slide, please. I'm sorry, previously the slide was Andy. That was the gentleman that was helping me renovate this. So again, our funding donors are the, of course, COPN for the Innovate Project funds. Thank you for that. For Home Depot, Tri-City Glass and Mirror, Andy, who you've seen in that picture. My company, Compassionate Coordinated Care. Again, your contribution has transformed a vision into a rolling clinic. Next slide, please. Inside the mobile clinic, you'll see we have a private consultation area, naloxone harm reduction resources, educational resources, and a basic medical screening space. Dr. Kennedy Gregg has seen multiple patients through here. In fact, this unit actually has a wheelchair ramp. I've used this to bring people to the emergency rooms as we've done some street outreach. Next slide, please. Again, services we provide, right? We're going to the encampments. We're meeting people where they are at. And interestingly enough, we're able to take Truro Med students first, second, third, and fourth year. They actually come out with us. They get hands-on activity under Dr. Kennedy Gregg's leadership. Again, naloxone distribution, fentanyl awareness education, peer counseling, health screening, treatment referrals, trying to get those warm handoff, harm reduction supplies, and of course, a lot of hygiene and basic needs. Next slide, please. Again, I'm all about prevention, intervention, and we've done a lot of community engagement, rural community. We've done a fentanyl high documentary. We've done some Rio Vista unmet service areas there. That's that picture there. That's the bus. Done some youth surveying with some of our team and staff members. This is another community partner there on the fourth picture on the right-hand side, doing surveys with youth at a bike shop. And then the bus actually was a helper for Santa's sleigh one time. We delivered 25 bikes to a local missionary. So again, increased services to rural high needs, greater youth, family engagement, and reduce stigma through visibility and access. Next slide, please. Again, our partners are Drug Safe Solano, our board, its coalition, Dr. KG Kennedy Gregg, who's here with me now, Dr. Fisher with 4 2nd Street, Dr. Townsend in the folder right there on the top, Solano Recovery Project, the Merrick Garcia Foundation, a family organization that my bride and I birthed when we lost our son. And our objective is to get a naloxone in every backpack in Solano County. Together we stand together and delivering care to those looking for hope. Next slide, please. Again, some partnerships here I want to point out. Again, Solano County Behavioral Health is a committed primary sponsor of our Drug Safe Solano Coalition through their opiate settlement funds, putting their money to work. As you can see, Truro Street Medicine with Vallejo Mobile Health. The VMH is a joint effort with 4 2nd Street and One Love. And you see Emily and also Michelle there from One Love. Again, Michelle Bunker and Dr. Emily Fisher, you see those photo deals. I'll go to the next slide in the interest of time. Again, progress and next steps, Drug Safe Solano, our harm reduction program. I thought this was vital. We serve over 500 people, community members through outreach and support. We launched free HIV, Hep C, STI testing through the 3rd Thursday, thanks to Solano Community Health. We expanded our mobile outreach every 2nd Saturday, building trust as participants transition into our fixed site, which is that Thursday. We continue to provide free harm reduction supplies and safe needle disposal at our fixed site. And what we're looking forward to is, again, launch ongoing outreach scheduled to broaden our reach, to expand mobile clinic services for a great impact and for growing our community and funding partnerships to sustain our work. So I want to make a quick comment, Dr. Emily and Dr. Michelle, thank you so much. I didn't want to overstep their leadership is vital as that previous slide that was just there. Next slide, please. Again, want to thank you all, COPN, for trusting us with your innovation project funds. We hope that our efforts demonstrate the heart that you lead. Again, as your community partner through Compassion Coordinated Care with the 3SS Toro efforts, we all truly feel blessed. We have been entrusted with helping support this initiative and to put the heart of our sponsoring provider. Frankly, the harm reduction services are under Dr. Kennedy Gregg's licensure. We don't have that embrace yet in our county, so we definitely appreciate her and allowing us an opportunity just to put her heart in motion by holding up her arms and the entire harm reduction team. So I tried to speed through that. Hope that wasn't too bad. At the bottom down there, that was Ariana, Arthur, and then also Sandy sitting on our bus. So that's it for me now. So thank you. Was there anything that you had, Dr. Kennedy Gregg?
Yeah, well, thank you, Raymond, for those kind words. Yeah, I wasn't sure if my teaching schedule today was going to allow me to be here, but I'm glad I was able to get coverage. So yeah, we are just incredibly grateful for the funds. I think the benefit, what we've really appreciated about the bus is like it's allowed a safe space. Like, you know, we were going out to the encampments before, but sometimes like it's nice to have a space that's a little more private to bring someone on to have a conversation in a more, you know, secure private area. We've even been able to do women's health exams on the bus, which is an area we're looking to expand because we know that pap smears often get kind of fall to the bottom of the priority list for some of our folks with all that they have going on. And so to be able to offer that vital service as well has been great. And then just we started doing some more point of care like hepatitis C testing and stuff, and being able to have a place for someone to sit to have their finger prick and everything is really great. And so we've really appreciated having that. And we hope to be able to continue to expand our outreach efforts more in our community under Raymond's awesome leadership. And he was the brains behind renovating this entire bus and everything, and continues to kind of like think bigger as to where we can go from here. So thanks everyone for your support.
And thank you all to all of our 4 speakers. I really want to just excellent programs that are currently in place. And looking at all of the names of those of you who've joined us from throughout the country, and we even have some people joining from other countries, just to appreciate all the work. There are a lot of questions. Unfortunately, we are down to 3 minutes. There was one question about long-term, long-action injectables and whether these can be used in this setting. And Reb or Ashley, could you comment on that, or Christine, specifically on the vans, the outreach vans, medical vans?
Yeah.
So
Go ahead, please.
this was actually my question for as one of the speakers. So I think one of my questions is just logistically how you guys have figured that out, because our group looked into it and we were told by the DA that long-acting injectables could only be provided through a mobile NTP, and we have not been able to partner with our local mobile NTP. So I don't know if you guys found a different workaround to that, or just like logistically. I don't know if that's a question Mary was referring to, but
Yes.
yeah.
I think that might just be your director. I don't think that is because we have like an FQ, we have several different agencies providing street medicine services under very different kinds of corporate structures. And I think that's more like that organizational policy and procedure issue that I was talking about versus state law in California. Because as long as you have it locked in your office once you pick it up, and then you bring it out in a lockbox, then you're able to administer it in the field. If you couldn't find the individual, put it back in the lockbox, bring it back to the office. You have so many days before then you'd return to pharmacy or Mendestroy. So that's what we found. And I've actually asked my close friend at our FQ, who's the director of street med and addiction med for PNP. So I'd be happy to send you what they have.
Yeah, that would be great. I did like, it was just, yeah, he was the one who spoke directly to the DEA, and he was like, wait, who's doing this? And he's like, oh, I'm not going to disclose any names. I don't want to get anyone in trouble. But like whoever he talked to at the DEA was very clear, like, nope, only a mobile NTP can take controlled substances out to the field. So I don't know, maybe it was just that DEA officer was like specifically interpreting the rules differently, but I can try to call again and look into it. Thanks.
Oh, with the first note of, really look at what's the detail and the circumstances, because as you say, sometimes the regulation within an organization and not a legal constraint.
Yeah,
So,
yeah, that's true.
thank you.
Thanks.
And unfortunately, we are at time. Again, I want to thank our speakers. And there have been several questions about the slides and the presentation that will be available on the National Overdose Prevention Network NOPN website. So you will have those available to you. And really look forward to hearing about the various programs going on throughout the country. We hope that you have found today's webinar useful, just some great ideas that can be implemented in communities. And appreciate all the innovation and above all, the incredible work all of you are doing to reduce overdoses in our country. Thank you everyone for joining us. Bye-bye.